Okay, so welcome to the late-breaking clinical trial session. Thank you for coming. Today we're going to have two presentations. The first one is a patient-focused presentation. Since the National Kidney Foundation is a patient-focused organization that's on patient preferences and prognostic expectations in management of acute decompensated heart failure and kidney disease at hospital admission and post-discharge. So looking forward to that. And then the second presentation will be on the APPLAUSE IgA nephropathy trial of iptacopan, the final 24-month data results. Log in to the NKF meetings site. We have some poll questions, so it'll be interesting to see your feedback. And we will have time for questions after each presentation, and I ask that you hold your questions till after the speaker presents. So without further ado, Sydney Wong she's a fourth-year medical student who's completing research at the Kidney Research Institute at the University of Washington, and she's focusing on the intersection between kidney diseases and heart failure. So patient preferences and prognostic expectations in the management of acute decompensated heart failure.
Hi, everyone. My name is Sydney, and I'm an early fourth-year medical student at the University of Washington. I'm actually missing a couple of days of my nephrology rotation to be here, but I feel very honored to be here today to discuss research that I've had the privilege of working with Dr. Nisha Bonsall over the past 8 months or so. I have no financial disclosures. Learning objectives for this presentation is to 1, characterize patient values, advanced care planning engagement, preferences for intensive therapies, and prognostic expectations in adults hospitalized with acute decompensated heart failure. 2, discuss how kidney dysfunction influences these care preferences, advanced care planning, and prognostic expectations. And 3, identify opportunities to integrate advanced care planning in order to improve goal-concordant care in this population. Our study specifically looked at hospitalization for acute decompensated heart failure, but I think it's important to frame our study in the broader picture of heart failure in general, in that heart failure patients represent a high-risk population, and heart failure represents a major public health problem, in that heart failure is a growing epidemic. Over 6.5 million people have heart failure in the United States, with more than 550,000 new diagnoses annually. And as this figure shows, these rates continue to rise, with an estimated prevalence of 8.5 million people with heart failure by 2030. And so heart failure patients represent a high-risk population for multiple reasons. One reason is the progressive nature of the disease that quickly leads to end-stage disease. Another reason is the adverse outcomes and complications associated with heart failure, including very high mortality and hospitalization rates. And then additionally, heart failure often coexists with comorbidities that impact prognosis and have direct consequences on other organs, including the kidneys. Looking at the specific relationship between the heart and the kidneys, there are cardiorenal interactions at play that link these two organs and thus contribute to some of these worse outcomes in these patients. Notably, it is through these 3 major mechanisms of hemodynamic mechanisms, most commonly being fluid retention, as well as hormonal mechanisms that activate the RAS system, and cardiovascular associated mechanisms that include inflammation and oxidation, that all negatively affect both cardiac and renal function. Kidney dysfunction is really common in patients with heart failure, affecting approximately 30 to 50% of these patients. And it's important to discuss kidney dysfunction and heart failure specifically, as it is related to worse outcomes, including electrolyte imbalances, diuretic resistance, frequent hospitalization, as well as a poorer prognosis. And so our study specifically looked at hospitalization for acute decompensated heart failure, or ADHF, which represents a really critical turning point in the disease course for these patients. ADHF hospitalization represents a sentinel event. It's a marker of signaling advanced disease with a poor prognosis both during hospital admission as well as after hospital discharge. ADHF hospitalization is often accompanied with a really high symptom burden that significantly impacts patients' quality of life. And a systematic review and meta-analysis by Tian Lan and their colleagues estimating mortality rates to be between 20 and 30% within 1 year of hospital discharge, as well as hospitalization admission rates of 20 to 25% within 30 days. So pretty high rates of both mortality and hospitalization. Kidney dysfunction in our study was defined as acute kidney injury or chronic kidney disease, and it's important to discuss in the context of ADHF hospitalization because it's common in these patients and it worsens outcomes for these patients. Approximately 30 to 60% of these patients have kidney dysfunction, and both acute kidney injury and chronic kidney disease are associated with these higher risks of mortality, higher rates of hospitalization, as well as longer hospital stays. And so at time of hospitalization for ADHF, these patients face complex treatment decisions for a multitude of different reasons. One reason is that heart failure has an unpredictable illness trajectory that makes it really difficult to estimate prognosis. And so as shown in this figure, patients with heart failure may remain relatively stable for periods of time, but then experience these sudden episodes of decompensation with sharp declines in function. Some patients may partially recover after hospitalization, while others continue to decline or die unexpectedly. And so rather than this steady linear progression in disease course, heart failure trajectory often consists of these recurring exacerbations and hospitalizations that are marked by uncertainty, making it really challenging for both clinicians and patients to know when to initiate goals of care or advanced care planning discussions. Additionally, as alluded to previously, heart failure often is accompanied by comorbidities that affect other organs and thus results in complex multidisciplinary care. Such care encompasses multiple high-intensive therapies, including but not limited to left ventricular assist devices, dialysis, as well as organ transplantation. And with such variety of options, further complicates decisions for these patients. And so the key point is that patients often face these really complex decisions, especially in the hospital setting, without having prior advanced care planning. What a review of the literature has shown is that the majority of patients with heart failure place more weight on quality of life over longevity. Advanced care planning rates are really low, especially in hospitalized heart failure patients, largely due to these discussions being delayed until death appears imminent. And then heart failure patients have also been shown to overestimate survival in comparison to model predicted life expectancies. Additionally, studies in seriously ill patients have shown that preferences and expectations are stable, while some other studies have shown that these preferences and expectations are dynamic, with such dynamic changes being typically prompted by changes in health and emotion. Importantly, most of these previous studies focused on ambulatory heart failure patients or advanced heart failure patients at the end of life, and also did not address the role of kidney dysfunction in this population. And so these gaps led to our research questions. First being that among patients hospitalized with ADHF, what are patient values regarding comfort and longevity, advanced care planning, treatment preferences for intensive therapies, and prognostic expectations, and do these differ in those with concomitant kidney dysfunction? And so we hypothesized that at index hospitalization, patients would tend to favor longevity-oriented care as well as intensive therapies, and that the presence of AKI or a history of CKD would be associated with significant differences in those preferences, and that patients would lean more towards comfort-oriented care, have lower preferences for intensive therapies, and have higher levels of advanced care planning engagement. Our second question was that how do these preferences and expectations change over time from the inpatient to outpatient setting, and again, do these differ in those with concomitant kidney dysfunction? We hypothesized that patients would move towards comfort-focused care in the outpatient setting and have higher levels of advanced care planning engagement after hospital discharge, and that, again, the presence of AKI or a history of CKD would be associated with significant differences in these outpatient survey responses. And so our study was a sub-study under the Parent Kidney Injury and Heart Failure Study, also known as KIND-HF. The KIND-HF study is a longitudinal observational study in which participants were recruited from 3 University of Washington affiliated hospitals in Seattle. Inclusion criteria for this study include physician-confirmed EDHF that included a review of the electronic health record, as well as confirmation by the treating physician. Additional inclusion criteria included patients had to be receiving IV diuretics and also had to be fluent in English. Exclusion criteria included dialysis, active infection requiring antibiotics, COVID, loop diuretic allergies, current or planned LVADs or Impella pumps, patients on ECMO, patients with history of solid organ or bone marrow transplant, pregnancy, infiltrative cardiomyopathy diagnoses, recent major cardiac procedures, as well as patients who were heart transplant candidates. Additional clinical variables were also obtained, including age, sex, race, and ethnicity were self-reported on the surveys, and then comorbidity information was obtained through both the electronic health record and patient interviews. Patient ejection fractions were recorded during index hospitalization from the research echoes. And so after inclusion and exclusion criteria were met, there were 400 total participants enrolled in the study, and of these 400, 297 completed an inpatient survey. Of these 297, there were 119 patients, about 40%, that had a history of CKD, 49 participants, about 16.5% that had an AKI on admission, and then 25 participants, about 10% that had both. Kidney dysfunction, again, for our study, was defined as the presence of AKI or CKD, with AKI being defined as a 0.3 increase or more in creatinine over 48 hours, or a 1.5 time increase in their baseline creatinine over 7 days. Baseline serum creatinine was defined as the most recent outpatient serum creatinine prior to hospitalization, but more than 7 days prior to admission. CKD was defined as an estimated GFR less than 60 and was ascertained through a review of ambulatory labs up to 1 year prior to admission. Notably, there were 12 deaths during index hospitalization. For the outpatient follow-up surveys, 206 participants completed at least one outpatient survey, and for our analysis purposes, the latest survey completed was used, which ended up being 24 surveys from the 3-month follow-up time point, 26 surveys from 6 months, and 156 surveys from 12 months post-discharge. Notably, there were 68 deaths within 12 months after hospital discharge in the outpatient setting. The survey that we used was adapted from Dr. Ann O'Hare's survey from the United States Renal Data System study about treatment preferences, also known as U-State, and we created a 13 multiple choice question that consisted of symmetrical questions that was made from this U-State survey that targeted end-stage renal disease patients, and we tailored our questions specifically to heart failure. In the inpatient setting, surveys were administered at any point during index hospitalization, while longitudinal survey data was collected at 3 different time points, 3 months, 6 months, and 12 months post-discharge. These outpatient follow-up surveys were administered by a single research coordinator during an in-person video or phone visit. And so our survey assessed 4 different domains. The first domain was patient values, in which we asked patients, if you were to become very sick in the future and were unable to speak for yourself, would you prefer a plan of medical care that focuses on extending life as much as possible, even if it means having more pain and discomfort, or would you prefer a plan of medical care that focuses on relieving pain and discomfort as much as possible, even if that meant not living as long? Answer options included extending life, even if that means having more pain and discomfort, relieving pain and discomfort as much as possible, even if that means not living as long, as well as an option of indicating being unsure. The second domain was advanced care planning, in which we had 4 questions targeted at this topic. The first 2 questions were related to durable power of attorney status and documentation of treatment patients would want or not want. Participants were asked, do you have a person who can make medical decisions for you if you were to become very sick and were unable to speak for yourself? And they were also asked, have you thought about the kinds of treatments that you would want or not want if you were to become very sick and were unable to speak for yourself? Answer options range from having not thought about this to having had signed official papers and discussed with relevant members. The other two advanced care planning targeted questions were related to preferred decisional roles. Participants were asked if you were to become very sick in the future and were facing a decision about whether to accept treatments to prolong your life that might increase your suffering, what role would you want to have in that decision? And answer options included patients saying that they would prefer to make the final decision, as well as they would prefer making final selection after seriously considering their doctor's opinion. They would prefer their doctor and themselves share responsibility in that decision, or that they would prefer their doctor make all decisions. Similarly, with respect to the role of family, participants were asked if you were to become very sick in the future and were facing a decision about whether to accept treatments to prolong your life that might increase your suffering, what role would you want your family to have in that decision, irrespective of involvement of your care team? Answer options were similar to previously. The third domain assessed by the survey was preferences for intensive therapies, including dialysis and heart pumps. Regarding dialysis, patients were asked, has any medical practitioner talked to you about starting dialysis if necessary? And they were then prompted to name the type of practitioner, such as a cardiologist, nephrologist, or a primary care provider, for example. They were then asked if you had to decide right now, would you want temporary dialysis if your kidneys were to shut down? And what if dialysis was permanent? Similarly, for heart pumps, we asked patients, has any medical practitioner talked to you about implanted heart pumps or an artificial heart to support your heart function if necessary? And they were again prompted to name what type of practitioner if they had such discussions. And they were then asked, if you had to decide right now, would you want to have a temporary implanted pump to support your heart function? And what if the heart pump needed to be permanent? And for the latter questions, answer options ranged from definitely yes, probably not, definitely not, and not sure. The fourth and final domain assessed by the survey was prognostic expectations. We asked patients, how long would you guess people your age with similar health conditions usually live? And survey responses ranged from less than 6 months to more than 10 years, as well as, again, an option of indicating being unsure. To analyze survey responses, baseline characteristics were summarized with descriptive statistics. We used a logistic regression for binary dependent variables and a multinomial logistic regression for categorical variables. To model trends over time from inpatient to the outpatient setting, we used a multinomial model with a random effect. And then the adjusted models were controlled for age, gender, race, and ejection fraction to assess the role of kidney dysfunction. Transitioning into the results of our study, first reviewing the findings from the inpatient surveys. First, looking at patient values. This figure shows participants' overall values regarding comfort versus longevity-oriented care during hospitalization. The first bar represents patients who prioritized comfort, specifically relieving pain and discomfort, even if that meant not living as long. And approximately 60% of participants selected this option. In contrast, approximately 20% of participants prioritized longevity-focused care, and then another about 20% indicated being unsure. The key takeaway from this figure is that the majority of hospitalized EDHF patients prioritized comfort over longevity at time of index hospitalization. We then examined whether kidney dysfunction influenced these treatment values. This table is organized by kidney dysfunction status across the columns, the first column being a history of CKD versus no CKD, the second column looking at AKI admission versus no AKI, and the third column being the combined group of patients with CKD or AKI versus patients with no kidney dysfunction. Rows represent the care preferences. And so looking across the table, all the odds ratios are relatively close to 1, and importantly, all the confidence intervals cross 1, meaning none of these associations were statistically significant. And so overall, the presence of AKI or a history of CKD did not meaningfully shift patient preferences toward either comfort or longevity-focused values. This slide summarizes advanced care planning engagement during hospitalization. And so starting with the bar chart, most participants had not completed formal advanced care planning documentation, with only about 40% having completed a durable power of attorney and discussed it with their surrogate decision maker at the time of hospitalization. Similarly, a minority of about 30% of inpatient participants had documented treatment preferences that they would want or not want. Regarding preferred decisional roles, most participants valued the opinions of their physician and family before making decisions themselves. And so now looking at whether kidney dysfunction influenced advanced care planning engagement, this table shows outcomes listed on the left, including having assigned durable power of attorney, documented treatment preferences, and the preferred involvement of doctors or family in decision-making on the left. And then the table is again organized by kidney dysfunction status across the columns. Again, the main pattern here is that the odds ratios are all very close to 1, and importantly, all the confidence intervals cross 1. And so taking this table together, these findings suggest that patients with kidney dysfunction are not engaging in advanced care planning more frequently than those without kidney dysfunction, despite their higher risk of adverse outcomes. And so next, looking at preferences for intensive therapies, this slide examines dialysis preferences and discussions. Starting with the figure on the left, most participants express favorability towards receiving dialysis if needed, with about 75% of the inpatient cohort indicating that they would want temporary dialysis if needed, and then 60% if permanent dialysis was needed. And then looking over at the figure on the right, most participants, about 90%, had never discussed dialysis with a healthcare provider prior to hospitalization. And so the big takeaway from this slide is that the willingness to undergo dialysis was really high, despite relatively limited prior discussions about dialysis. And so this table evaluates how kidney dysfunction affected dialysis discussions and preferences. The most striking finding is in the first row. Looking at dialysis discussions, patients with a history of CKD had over 7 times higher odds of having discussed dialysis with a provider compared to patients without CKD. The confidence interval did not cross 1, making this a statistically significant association. However, despite having had more discussions, chronic kidney disease was not associated with different dialysis preferences themselves. The odds ratios for wanting temporary or permanent dialysis were both close to 1 and non-significant. AKI also did not significantly influence dialysis preferences, and they also did not influence dialysis discussions. Overall, kidney dysfunction, specifically chronic kidney disease, increased exposure to dialysis discussions, but did not appear to change preferences to undergo dialysis. This slide shows a very similar pattern for implanted heart pumps. On the left, about 70% of patients expressed willingness to receive a temporary pump, while 63% indicated positive preference to receive a permanent heart pump if necessary. And then looking on the right, the figure shows discussions about heart pumps, and that most patients, 71%, had not discussed heart pumps with a provider prior to hospitalization. If these discussions were happening, most of the time it was with a cardiologist. And so overall, most participants expressed a favorable preference for heart pumps. Very few reported having discussed this therapy with a healthcare provider, though. And so this again demonstrates that there's a relatively high acceptance of intensive therapies despite limited prior discussions or counseling about these therapies. This table evaluates the impact of kidney dysfunction on heart pump discussions and preferences. Interestingly, patients with a history of CKD had nearly twice the odds of having discussed heart pumps with clinicians, with an odds ratio of 1.94 and a statistically significant confidence interval. However, similarly to dialysis, CKD and AKI were not associated with different preferences for temporary or permanent heart pumps. And so once again, kidney dysfunction increased prior exposure to discussions, but did not meaningfully alter treatment preferences. Looking at the last domain of our results, being prognostic expectations, starting with the figure which shows the distribution of participant responses regarding prognostic expectations during index hospitalization. Notably, a very small proportion of participants predicted prognoses of less than 1 year, while most participants, about 40%, had prognostic expectations of 5 years or more. and then about a third of the inpatient cohort indicated being unsure. And so importantly, 80 participants, approximately 30% of the inpatient cohort died within 12 months of index hospitalization. And among those who died, more than half had a history of chronic kidney disease, about 1/5 had an AKI on admission, and 12.5% had both. And so I think this is one of the most striking findings of our study. Of these 80 participants, only 4 of them, just 5%, had accurately predicted a prognosis of less than 1 year. And so this finding highlights a substantial misalignment between patients' expectations and their actual clinical outcomes. Looking at prognostic expectations in the setting of AKI and CKD, this table shows prognostic expectations on the left, and again, the kidney dysfunction statuses in the columns. The major finding here is that patients with an AKI admission had about an 8 times higher odds of predicting survival to be less than 1 year. The confidence interval does not include 1, indicating this to be statistically significant, although I will note that the confidence interval is pretty wide, ranging from 1.7 to 36.2, suggesting some uncertainty in the magnitude of this significance. In contrast, however, a history of chronic kidney disease alone was not significantly associated with shorter prognostic expectations. Shifting to looking at expectations for the longer survival categories of 1 to 5 years or greater than 5 years, AKI or CKD status did not significantly impact those expectations. And so importantly, expectations, overall this slide I think really just suggests that acute illness may be influenced by that acute illness may influence short-term perceptions of prognosis more than chronic kidney disease alone. Transitioning to the longitudinal portion of our study, looking at how survey responses across these 4 domains changed after hospital discharge into the outpatient setting. This figure compares inpatient versus outpatient preferences regarding comfort and longevity. The orange bars represent inpatient responses, while purple represents outpatient. Most participants continued to prioritize comfort-focused care after discharge, with about 53% of outpatient responses indicating this preference. However, there was also an increase in uncertainty over time, shown by the taller purple unsure bar. The table on this slide shows the adjusted odds ratios using unsure as the reference category. Participants, interestingly, had significantly lower odds of preferring comfort-focused care in the outpatient setting, with an odds ratio of 0.66 and a confidence interval that narrowly excluded 1. The decrease in longevity preference was not statistically significant, but overall, this slide really just suggests that values remained relatively stable, though uncertainty may have increased somewhat after discharge. This slide examines changes in advanced care planning engagement over time. Looking across the table, odds ratios for durable power of attorney completion, documented treatment preferences, as well as physician or family involvement in decisions were all close to 1, and importantly, every confidence interval crossed 1, indicating no statistically significant changes over time. And so advanced care planning engagement remained persistently limited in the outpatient setting, even after hospitalization. This slide evaluates the longitudinal changes in intensive therapy discussions and preferences over time for both dialysis, shown on the left table, and heart pumps, shown on the right table. Discussions with clinicians did not significantly increase over time, and treatment preferences for both dialysis and heart pumps remained largely unchanged. Again, nearly all the confidence intervals crossed 1, indicating no statistically significant longitudinal shifts, and overall patterns that were observed during hospitalization largely persisted into the outpatient setting. Finally, looking at prognostic expectations over time, most patients did not significantly change their expectations after discharge, with about half reporting no change. Overall, expectations remained quite optimistic, even in the outpatient setting. We did see some movement. Some patients became more uncertain, while others shifted toward a more definitive estimate. but these changes were relatively modest. And so overall, similar to the other domains, prognostic expectations remained largely stable over time. I know that was a lot of data. And so just to summarize, I think the key major findings from our study is that first, there was this discordance in preferences and that most patients prioritized comfort-oriented care, yet many simultaneously expressed willingness to undergo intensive therapies like dialysis and heart pumps. Advanced care planning engagement was very low in our study, both during index hospitalization as well as post-discharge. Prognostic expectations were highly optimistic and substantially overestimated survival. And then, importantly, kidney dysfunction, defined again as the presence of AKI or a history of CKD, did not meaningfully affect preferences or expectations for these patients. And these preferences and expectations, the patterns remained relatively stable over time in our study. And so altogether, I think these findings highlight major gaps that exist between patient values, prognostic understanding, and their real-world clinical outcomes. And these are for both patients with and without concomitant kidney dysfunction. And so our study extends and expands on prior literature in several important ways. First, we include patients hospitalized for acute decompensated heart failure, which again represents a critical turning point in disease and has its own implications that are different from ambulatory or end-of-life patients. Our study also provides longitudinal assessment for these patients over time from inpatient to the outpatient setting. And then importantly, we incorporated the role of kidney dysfunction and its influence on these preferences and expectations. And then overall, I think our study identifies persistent gaps in advanced care planning and prognostic understanding for these patients. The major clinical implication from our study's findings is that there's a need to fill a major gap in physician-patient communication, as well as a need to better align care with patient goals and values. Our study's findings suggest opportunities to improve patient education and improve patients' understanding of their heart failure severity and kidney dysfunction. Our study also shows a need to integrate prognosis into shared decision-making, as well as to initiate advanced care planning discussions earlier in disease course and revisit these discussions longitudinally rather than waiting until critical illness precipitates. Hospitalization for acute decompensated heart failure thus may represent a particularly important opportunity to initiate or revisit these goals of care discussions, and then kidney dysfunction itself may serve as an invitation for clinicians to engage in these discussions as well. And so future work should focus on developing interventions that improve prognostic understanding and support shared decision-making in these patients. Potential areas include structured advanced care planning interventions during hospitalization, communication tools that address multi-organ disease risk, as well as decision aids to help patients better understand intensive therapies and likely outcomes. Ultimately, the goal is to improve goal concordant care for this very high risk, very sick population. And before I close, I just want to acknowledge and thank the people who made this project possible. First and foremost, I'd like to thank my mentor, Dr. Nisha Bonsall, who unfortunately couldn't be here today, but she's been incredibly influential both in this project and in like my own development. And I feel really, really grateful for the opportunity to work with her. I would also like to thank David Prince, who did all of the analysis for this project and would not have been possible without him. I would also like to thank our broader study team, including Doctors Catherine Butler, Ann O'Hare, Daniel Lamb, Kevin O'Brien, and Millette Asefa, as well as Dawn Lum and our research coordinators, whose work administering surveys and conducting all the patient interviews make the study possible. Also, we'd just like to acknowledge the NIH for funding this study, and then the Kidney Research Institute at the University of Washington for a really, really wonderful research experience. And then last but not least, and most importantly, a thank you to the patients who participated in this study and shared their perspectives. their contributions are what make this work and will continue to make this work very meaningful. So.
Thank you very much. And, as a fourth-year medical student, I think coming here must be a little bit intimidating. So, I want to congratulate you for seeing this through. You're going to do internal medicine, and we're going to have you sign for a nephrology fellowship shortly. I want to see if there are any questions from the audience, but one question that I had to do with interactions with specialists. So you mentioned that the cardiologist discussed the heart pumps, and presumably the nephrologist discussed the dialysis decision-making. Do we know anything about the interaction in the inpatient setting? And also, probably more importantly, there was no real difference between inpatient and outpatient surveys that I gleaned. So were there nephrology visits after hospitalization that could have impacted those survey differences?
Yeah, that's a good question. That was the one concern that we had of our study, that during index hospitalization, having this survey, if it would prompt changes both during hospital stay as well as post-discharge. However, our survey results, I think, really showed that patients were not engaging more proactively or in more advanced care planning. And so from what we saw, I think that there could be better follow-up initiated by nephrologists, by all the members of the care team.
Dr. Rovin has a question. Yes.
Thank you. That was spectacular. I wish some of our fellows would do that. No offense to any of our fellows here. When you think about the population that you're dealing with, some thoughts came to mind as I was listening. One is, how do you factor for socioeconomic status, educational status? I mean, I think those sorts of things really make a difference in these decision-making that we get at the end of life.
Yeah, I completely agree. And I think that a lot of these patients also have caregivers, and that was something that we did not include in our study, but I believe would be really, really beneficial for patients with, different socioeconomic backgrounds, different education backgrounds. I think the big takeaway for Dr. Bonsall and I was that these discussions were really not happening very much at all. And so I think that's the first step, is just to actually initiate and have such discussions with patients.
Yeah, I believe that to be true. Since almost everyone in here is a nephrologist, and I hear you're going to be one too, one of the things that in our own practice I've seen over many, many years is that as soon as a person has kidney disease, everyone else is hands off. So the primary care physician doesn't participate anymore. They just say, talk to your nephrologist. The cardiologist may, only about the heart, but then they don't discuss it with us until they're ready to put the pump in. So I think that the idea that we're not communicating between ourselves as physicians or with a point person who should be the person's primary care physician is really important, and I don't know how to fix that. I mean, it's good to identify the problem, but now the next step for when you're a fellow is, how do you fix it? You don't have to answer that. If you knew the answer to that, boy, you can give my talk too.
I share the same question as you.
Okay, good.
Hey, Josh Lowentritt, nephrologist in New Orleans. This is really timely. You may not be aware as you go to your residency, but by the time you're in your fellowship in 2030, hospitals, the base year for making a real good faith effort to address advanced care planning in hospitals in 2028. If they don't do it, they're going to get their rates cut in 2030. So by the time you're a fellow, you're going to need to be an expert on this, and the whole healthcare system needs you.
Thank you very much. That was great. And so 2 years ago, we had, I think it was Dana Retzik present the 9-month applause trial data that culminated in, I think, in part, accelerated FDA approval. And the 24-month data were highly anticipated. So without further ado, we're going to hear about the applause IgA nephropathy trial of iptacopan, the final 24-month results. And this is Brad Rovin, who's well known as the chief of nephrology. He's an internationally regarded expert in glomerular diseases and a professor at the Ohio State University Wexner Medical Center.
All right. Well, a couple of things. First, I think we're taking Wexner out of our name, or at least I am on my slides. I won't get into politics. And second, I hope everyone hopes I can do as good as Sydney. And third, I'm not the chief anymore. I stepped down from that job in January. So now that we have our facts straight, how about some fun with IgA nephropathy? All right, so, and just to be clear, Donna was supposed to do this talk, but she's too busy, so they got a pinch hitter. But I'm happy to do it. And I consult with a lot of the companies who do IgA therapeutics. So the objectives of this are to understand the role of the alternative complement pathway. Activation is a key driver for IgA nephropathy. Understand the potential for complement inhibition to address immune complex-mediated glomerular inflammation and nephron loss, and then to evaluate the final applause IgA efficiency and safety data using iptacopan for IgA nephropathy. And you are quite correct. At 9 months, we had, based on the decrease in proteinuria, accelerated approval for iptacopan, so it's been used for that period of time and has been available. And then the 24-month data was what we were waiting for, which is, does this impact kidney function over time? And now, of course, the drug is being considered by the FDA for full approval, which we hope will come soon. Okay, so as everyone knows, just to get on the same page, IgAN is a progressive, heterogeneous, immune-mediated disease. It's the most common primary glomerular disease worldwide, and as you know, high incidence in Asian areas. Patients with IgAN present with a variable disease course and a lot of heterogeneity, pretty much like all of our glomerular diseases. And patients have a chronic progressive disease course marked by persistent proteinuria and may also exhibit glomerular inflammation. And, you know, since we have time, which is different than my first session standing at the podium earlier today where we ran out of time, just to say it's really important that we understand this as a community, that it's not just the RaDaR data from the UK, which indicated that patients with IgA nephropathy and small levels of proteinuria can have progressive disease such that many of them will reach renal replacement therapy need in their lifetime. This has now been validated in cohorts from around the world, China, other parts of Europe, and the United States. So our idea, I'm old enough to really know that when I was a fellow, we were taught IgA nephropathy is a benign disease, don't worry about it, nobody gets into trouble from it. And that's clearly not the case. And so this idea of having new therapeutics is, you know, really mind-boggling for me because this is not something we had for most of my career. The other thing that's really important is to understand the pathogenesis of IgA nephropathy, at least what we think is the pathogenesis, and we can talk about whether this is true or not, or what else needs to be done to verify it. But by considering the pathogenesis and then considering where these new drugs act, we can see where they fit into the treatment scheme and what they might be anticipated to do, which is really good. Okay, so IgA nephropathy, as you all know, the antigen in IgA nephropathy is presumably a galactose-deficient IgA molecule, maybe coming from the gut or maybe coming from plasma cells that have traversed the gut and are in the circulation. Now, I will tell you that all of you make galactose-deficient IgA. I happen to make a lot of it because I use myself as a control in my experiments. So the question is my IgA pathogenic? I hope not. So far I'm doing okay, but I think that the idea of galactose-deficient IgA as an antigen is very appealing, but we know that many of us have it in this room and we don't get IgA nephropathy. So maybe it's really important in the future to identify what galactose-deficient IgA is actually pathogenic. So keep that in mind. And if Donna was here, maybe I would ask her, but she and her group have developed a galactose-deficient IgA assay that we might be able to use clinically. And we've been playing with it in the laboratory. And IgA patients have very high levels. Controls have high levels. Patients with lupus have high levels. Patients with other disease have high levels, but they don't have IgA nephropathy. So we have to sort of start thinking about fine-tuning the idea of the pathogenesis. Nonetheless, for practical purposes, hit one is the production of excess galactose-deficient IgA. And then this is a build-out slide. And then I think what really makes sense to me is that people are predisposed genetically to make autoantibodies against the galactose-deficient IgA and eventually make immune complexes that land in the glomerular mesangium. Now, if you talk to a renal pathologist, you'll understand that if they use confocal microscopy, you can probably find complement and IgG in all cases of IgA nephropathy. In routine pathology, using light microscopy and regular immunofluorescence, it's variable, but a lot of our patients have complement in their mesangium, and they also have IgG. Nonetheless, we also know that galactose-deficient IgA is self-aggregating, and that might form immune complexes or immune aggregates, because they're not really immune complexes, that drop into the mesangium. And so once they're in the mesangium, this is hit 2, is forming these aggregates or immune complexes. Then, of course, they land into the mesangium. Hit 3 is the formation. Hit 4 is the complexes are there, and they're actually initiating a response in the glomerular mesangium that is really wide-ranging. And that response includes complement activation, inflammation, activation of the renin-angiotensin system, activation of the endothelin system. And when we get to our really cool KDIGO diagram of where these drugs go, we'll see that we now have drugs that actually address all of these hits across the IgA spectrum, with more coming, which is extraordinarily exciting. Okay, now this is a really cool slide. I will confess I did not make this because it moves. And I don't know, but it's really irritating, so I want it to stop moving. So I'll do that. Okay, so this is the complement system, and the alternative complement pathway is thought to be highly involved in IgA nephropathy. There is a question of whether the lectin pathway may be involved as well, and if those of you who are students of IgA nephropathy know, we used to have a trial with a lectin pathway inhibitor. It actually did not succeed and it was stopped. However, there was a real question of whether or not the dosing of that particular monoclonal antibody was appropriate to actually significantly inhibit the complement pathway. And so what this thing was illustrating with the movement is that with the alternative pathway, it's always on, and it's always ready to fire into action. And it is really important to be able to control that, and it's hard to control that. Factor D is the most important rate-limiting enzyme for the alternative pathway. Targeting factor D is really, really hard, because if you have a little bit of factor D available, the alternative pathway goes. And then that circle makes it build up, and you have you just can't control it. Factor B is a really good target because after factor D, factor B comes into play. Factor B can be targeted, and that's what iptacopan does, the drug we're talking about today. Okay. Now, this, of course, is a glomerulus, and this is also animated. We talked a little bit about this. Mesangial proliferation may be stimulated by complement split products. The membrane attack complex can actually damage cell membranes. It doesn't kill nucleated cells like it does really well with bacteria, but it certainly can change signaling, cytokine production, et cetera, in those cells. And then, let's see. C3 and MAC deposition contribute to tubular interstitial fibrosis, and I'd like to discuss this a little bit more if we have a nice discussion going after the talk about what is our anticipation of what complement inhibitors in IgA nephropathy may actually be doing. And then the MAC actually promotes matrix accumulation as well. Okay. So this is from the KDIGO, and this is the updated one. We're having to update, pretty much nightly when I go to bed. I have to update the KDIGO guidelines because that's how quickly the data are coming forward. But seriously, when we published the guidelines last year, 2025, only 2 of the drugs or 3 of the drugs had approval, and now a whole bunch do, and a whole bunch more are heading toward approval, accelerated and full. And so we updated this to try and keep up with this. And so what we're saying in patients with IgA nephropathy is to target this as a glomerular disease like any other immune-mediated glomerular disease and try to target the immunology of the disease. Now, you would never say to a lupus patient, we'll put you on a RAS inhibitor and see how you do after a couple years. We want to turn off the immunology, the immunopathogenesis of the disease. The same thing with IgA nephropathy. On the right side of this diagram is consider the generic responses to IgAN nephron loss. And why do we have to consider this? Well, you'll see when we get to the patient population enrolled in the APPLAUSE trial, and it's very similar to all the other patient populations, their starting GFRs are really not very good. Okay, we do not diagnose IgA nephropathy early enough, and so this disease tends to sort of boil along, maybe under a clinical observation, maybe not, but most of my IgA patients come to me after seeing the urologist, right? You guys know this, you're out in the community, they've seen the urologist 3 or 4 times, they might get a couple of scopes, and then all of a sudden, well, this isn't a structural lesion of the bladder. And so we're wasting time. And that time is my favorite phrase, time is nephrons in immunologic diseases and inflammatory diseases. And so when you do that, you almost always have CKD. Very seldom do I see a de novo IgA patient with perfect renal function. It just doesn't happen. They don't get referred early enough. So Sydney, talking about communication, we have to communicate with lots of physicians. So we are advocating to do something about the chronic kidney disease simultaneously with doing something about the immunology. Today we're here to talk about the immunology, but don't forget we have lots of things we can do now for chronic kidney disease to slow progression. RAS inhibition, which we've used for years, you know that. Now we have aldosterone antagonists, we have SGLT2 inhibitors, we have GLP-1 receptor antagonists, and so we have a whole cornucopia of things we can choose, and we'll have to figure out how to do that. And of course, I'm piling medicines on top of medicines, and then we have to talk about adherence, and we have to talk about cost. Thank God I'm not going to do that today because that would be more than an hour lecture. So in terms of managing on the left side the IgAN-specific drivers for nephron loss, we have hits 1 through 3. Hits 1 through 3 make a lot of sense to group them together because this is the generation of galactose-deficient IgA and the response to galactose-deficient IgA. And so we have targeted release budesonide, which you know is presumably targets the Peyer's patches and tamps down the production of galactose-deficient IgA. We know from the trials of NEFCON that they do drop the levels of galactose-deficient IgA. Now we have APRIL and APRIL-BAFF inhibitors that do a similar thing, working directly on modulating the B cells. And then we have systemic glucocorticoids. Now, systemic glucocorticoids, it's a love-hate relationship. They're great drugs. They carry a lot of side effects, as you know. And we sort of have the triangle, an inverted triangle with not having much to do at the synthesis of galactose-deficient IgA and a lot to do with inflammation and hitting HIT4, which is kidney damage. Now, this was not the original way I drew this because I drew it, but they said you're changing too many things at once. It turns out now that we've seen the results of the testing trial, and not unexpectedly, systemic glucocorticoids reduce galactose-deficient IgA as well. So to me, this should be sort of a rectangular box across. And you can use steroids, and in many parts of the world, that's all you have to use. I'm not advocating it, I'm not denying it. Sometimes you have to use steroids, but now we have things that really work, in my opinion, a lot better and with far fewer side effects. Okay, so we're coming down the pike here, and we have APRIL-BAFF inhibitors, and then you see the complement inhibitors in here. And the way we've outlined the complement inhibitors is they're not necessarily targeting the B cells per se, but they're targeting the consequences of the deposition of immune aggregates or immune complexes in the glomerular mesangium, and those consequences are complement activation and inflammation. So they're targeting HIT4. And then on the right side, not to forget the other new drugs, which are the endothelin receptor antagonists, we have those in the generic responses to chronic kidney disease because as you lose nephrons, the renin-angiotensin system revs up, the endothelin system is almost an exact duplicate backup system, if you will. I don't know if it's backup. I don't know one is more important than the other. But the point is we put it there, but you can actually have that slide over to HIT4 as well because in HIT4 you're activating all of these systems. So a lot of these drugs do a lot of things. We've sort of targeted in this paper the most prominent thing that they do. But again, most of these drugs have what appear to be beneficial off-target effects. Okay. So we're back to this pathway, and I guess this is where iptacopan comes in. So iptacopan comes in right there at factor B and turns off the alternative pathway. And so now finally get to the design of the APPLAUSE trial. The design of the APPLAUSE trial is like all of the other trials, and I'm not saying that in a negative way. This was a phenomenal effort by the ASN, the Kidney Health Initiative, and the FDA in a public-private partnership to work out how we could design trials for rare glomerular diseases so that we could get drugs accepted without having to wait until patients go on to end-stage kidney disease, which no pharma can support, no one can support because it takes a long time. And so the way this was done was using a lot of data, mostly trial-level meta-analysis. We found that if you reduce proteinuria by at least 30% at about 9 months, looking at all the trial data put together, this was done by the Tufts group, Leslie Inker and her colleagues. When you look at this, you know that that correlates with GFR benefit in the future. And so the FDA said, okay, we will accept that for accelerated approval with the contingency that the trials continue for 2 years so we see what the GFR benefit is over time. And so that's how all these trials were designed. Very exciting that we were able to carry this out. And more exciting than that is that we were able as a community to carry these trials out when drugs were approved at 9 months without breaking the blind. These went on blinded. This was absolutely amazing. Now, going forward, we have no idea how to do clinical trials in IgA nephropathy because there is no placebo anymore. We have to use... Ethically, we now have drugs that treat the disease really well. And in our country, these drugs are available. Around the world, it's really hit or miss. So last week, or it was 2 weeks ago, we had a very nice NKF conference where we talked about clinical trial design. Some of the folks in the room were there. We're trying to work this out. But I assure you, we're not going to stop development of IgA drugs. We just have to figure out how to do it in the new environment. So this is the trial design. The endpoint was at 9 months. That's what we talked about, or Donna talked about last year. And then the end of the study was month 24, and that's where we looked at the GFR data. And of course, we wanted to make sure the proteinuria data was stable. And so this is just what I told you. And so what you see here is a recap of what was presented almost certainly last year. But you see the 24-hour UPCR on the left and the first morning void urine on the right. And you can see that the decline in proteinuria with iptacopan is very rapid and significant, very quickly significant, and differentiates itself from the placebo group. And placebo is a bad term. There's a placebo iptacopan pill, but these patients were all being treated with what was standard of care at the time, RAS inhibition at maxed out RAS inhibition. Okay, so they were not untreated patients, and that's a little confusing sometimes, especially when you try to talk to patients about clinical trials. So this allowed FDA approval on an accelerated basis, and then the final analysis, of course, is month 24, and we looked at the annualized GFR slope to see if there was a difference. So this is the diagram of the study, and you can see the number of patients that were screened, the number of patients that underwent randomization, and then you see sort of where these patients wound up. But about 92% of the patients completed the study. 76% or 76 patients who had a protocol described treatment discontinuation. The majority of the reason that they stopped was that they had a decline in GFR of greater than 30%. This is the demographics, and let's see, where is the GFR line? So you can see what the mean GFR is in the iptacopan group and the placebo group. It's 63 and 66. So this is really, really typical of what we're seeing in all of our IgA trials. So these folks already have chronic kidney disease. And I don't care, I don't know who invented that CKD is a GFR less than 60. I never, ever want my GFR to be less than 60 to be called normal. Okay? So these people have significantly impaired kidney function to start with. And remember, that's the mean. So we have people on either side of that. Okay, the other thing that I really want to point out, which is now changing in the trials, is the very last column, or the last two rows, one ACE and ARB. So obviously that was the placebo group, and all of these drugs are added on to the placebo arm, to a placebo, which is standard of care, which is ACE or ARB. But then SGLT2 use. This trial has been around for a little while, and so the use of SGLT2 inhibitors in this trial was only about 20% of the population. Now, the trials that were started a little bit after, which are most of the B-cell modulating trials, actually about 50%, 40 to 50% of the patients are on SGLT2 inhibitors. And it's really cool because if you do a sub-analysis, having the SGLT2 on board doesn't matter. It does not detract from what the drug does, which is really important for us to know. So the counter-argument of that is it's additive. That's how I think about it. Okay, what else? I think this is good. Oh, the amount of proteinuria here was quite high, 1.7 and 1.8 grams per day. That's a little bit higher than most of the trials to date. And the other thing that's good, and I criticize this a lot of those of you who've heard me speak, most of the trials have used historical kidney biopsies. That does us no good with trying to relate MEST scores and pathology with what's going on in the kidney. But this trial, the time between biopsy and enrolling in the trial was about 1 year. So this was the shortest duration. And I'm going to call that out a little bit when we get to the sub-analyses and the forest plots. Okay. So this is the final analysis. So here's the GFR slope. And so GFR slope is simply what the GFR is doing over time. And this is in mil per minute per 1.73 meters squared per year. So we've annualized the slope. And so -6 in the placebo group means that these folks are losing 6 mils per minute per meter squared per year of GFR. And so you can take their age, compute how many years it will take for them to go to a GFR of 15, and most of them will be on dialysis. Iptacopan significantly decreased that. It didn't make the slope go to 0, so it didn't cure, if you want to use that as a cure, but it significantly protected the kidney function, -3 mil per minute per 1.373 meters squared. And this is what this looks like over time, a very nice stabilization of the GFR over the first 3 months, and then you see the slope, the decline is much less in the iptacopan versus the placebo group. Okay. So here's some interesting sub-analyses. These were pre-specified, so that's important. These are forest plots. So one side favors placebo, one side favors iptacopan, and the line in the middle is sort of neutral and not significant. But what you can see just glancing at this, and I hope you can see some of this, but I'll describe what I think is really relevant. In general, everything's to the right. So all of these subgroups were okay with iptacopan. It worked. And that included age above or below 45, sex, regions of the world. Interestingly, North America was, the point estimate was on the iptacopan side, but it crossed the line, so that one wasn't exactly significant. Really weird. But anyway, Asia, non-Asia, GFR categories. Now, what about the biopsy? And this is where I think this is really important, because this is a biopsy, these biopsies were more proximal than most of the other trials. And remember, I've just spent the last, 15 minutes trying to convince you that iptacopan is hitting complement, which is inflammatory, and it's getting rid of inflammation, and that's where it works. However, if you look at M1 and M0, iptacopan works fine for either one. Now, you can make the argument that an M lesion, a mesangial lesion, is, well, maybe that's inflammatory because you can hide some cells in there that are immune cells. Okay, let's leave that alone. E1 is inflammatory. I don't think anyone can argue that endocapillary hypercellularity is not an inflammatory lesion, and this works. Iptacopan works, E1 or E0. The S lesions, I've always thought of S lesions as being chronic, but now it turns out S lesions with adhesions and podocyte effacement right over the S lesion might be inflammatory. So is this working on inflammatory S lesions or chronic S lesions? I don't know. But I think all of us can agree that T lesions, T1, T2, are not inflammatory, and those are scar, and it works if you have scar. So this really begs the question of what is iptacopan doing? Is it solely anti-inflammatory in the IgA area, or is it actually doing other things that might be relevant to chronic damage, fibrosis? And some of you were at the Cleveland Clinic last week, and I gave a talk on complement, and it turns out that complement in the tubulointerstitial space may actually promote fibrosis, and controlling complement in the tubulointerstitial space, we don't know that for IgA, but we know it in experimental models of unilateral ureteral obstruction, maybe that's important. So maybe this is doing two things, two beneficial things. So that's great. Okay. Now let's see. This is first morning void urines. I think we're showing this because one of the things we did a long time ago with lupus, and then we're doing more and more with other glomerular diseases, is can we make these trials more user-friendly to patients? And does the first morning void reflect the 24-hour urine proteinuria in an easier fashion? And the answer is probably yes. certainly in patients who are young. It may not be so good in older people who have chronic kidney disease who get up a lot in the evening and the night and have to urinate. But I think for the most part, we're pushing towards simplifying our trials. So just a point for those folks who want to be trialists in the future. Okay. And then this is important. And this is the proportion of patients reaching a 24-hour urine protein to creatinine ratio less than 1 gram per gram. So you can see that if you remember in the old days, the KDIGO guidelines and our mantra as nephrologists was get a person with IgA, their proteinuria below 1 gram a day, and they're solid for the rest of their life. Our new mantra is get the proteinuria as low as you possibly can without making the patient so unstable that they can't stand up because you've lowered their blood pressure. However, although I asked for those data to present here, they are embargoed at the ERA. So we'll have to look at patients with proteinuria of 0.3 at the ERA in 2 weeks, which is obviously going to be fewer than these patients, but we sort of consider a proteinuria below 300 milligrams a day as complete response in IgA nephropathy if the hematuria goes away. Nonetheless, we have a significant difference between patients reaching less than 1 gram a day in the placebo versus the iptacopan group. Okay, and then the same sort of thing was done. The forest plots were done. Of course, we did this to confuse you. Now iptacopan is on the left and the placebo is on the right of the forest plot. But for looking at proteinuria and different subgroups, iptacopan was favored, and including all of the histologic parameters I discussed earlier. Okay, and then this is a composite kidney endpoint, which is kidney failure and some other things which are defined here, or they're not defined here. They're in the footnote. If you can read that, more power to you. But this is a secondary analysis. We did good. Okay. Okay. One of the most important things in treating glomerular diseases is patient-reported outcomes. This is really becoming prominent. Those of you who take care of lupus patients know that you can get everything to look beautifully on the balance sheet, and they still have terrible, terrible fatigue. We did a FACIT score, which is a fatigue self-reported outcome. And you can see here that improvement in fatigue follows the y-axis increasing. I had to ask because I don't use this and I don't know what these numbers mean, but this is not significant. And the reality was the IgA patients mostly didn't have an overburden of fatigue. So this is they had fatigue levels comparable to the normal population. We're all fatigued. We get up early, go to these meetings, party all night, come to the next day. We're fatigued, but we don't have profound fatigue. What about hematuria? Hematuria is sort of the biomarker that is creating the latest group of controversies in IgA nephropathy. These were measured by dipstick, an embarrassment, I would say, for worldwide nephrologists not to be able to do a urinalysis. Nonetheless, this is dipstick hematuria, and you can see that it resolves nicely over time. It doesn't completely go away, but in a substantial portion of patients it decreases. And I'm not criticizing the APPLAUSE trial. No trial looked at anything other than a dipstick. Okay, what about safety? The safety is listed here. You can see any treatment emergent adverse event. Serious adverse events were 12 and 11% in both groups, really not different. And then the TEAs suspected to be related to study treatment or leading to discontinuation are highlighted at the bottom. No difference between the two groups, and very few discontinuations based on an adverse event. Serious infections occurred in 6.7% of the patients with iptacopan, and 5 of the patients, or 2.1% of the patients on placebo. Obviously, we're very concerned with a complement inhibitor about encapsulated organisms. You can see there were no meningitis case, H. meningitis or H. influenza cases
N meningitis and H influenza cases. There were some cases with strep pneumoniae. They resolved. But really, for all the complement drugs, this does take vaccination. And then prior to vaccination kicking in, you probably need to treat with antibiotics. And I would say that since you don't want to delay treatment for the vaccination, since the CDC now says you need 3 rounds of vaccination over the course of nearly a year, you don't want to delay treatment, most patients will start with antibiotics. And now, last week I was asked a really interesting question. Somebody said to me, well, the proteinuria and the GFR all get better because these drugs just control the blood pressure. And I said, no, well, they don't make the blood pressure worse, but they don't make it better either. And you can see here that the systolic and diastolic blood pressures in both groups were similar. And then there's no difference in liver functions or cholesterol or triglycerides. Why do I say this? We seem to see some liver function abnormalities with complement inhibitors, and I think that's important as well to point out we didn't see that. So now, this is unbelievable. I'm finishing early, and there's plenty of time for questions, and we can have some fun. So in the APPLAUSE trial, iptacopan demonstrated a statistically significant and clinically meaningful improvement in kidney function, shown by the annualized total GFR slope over 24 months, and about a 43% reduction in the likelihood of progression to kidney failure compared with placebo. There was a rapid and sustained reduction in proteinuria, consistent across all of the pre-specified subgroups, and hematuria improved as well. It was well tolerated, the safety profile was good, and we didn't have any unexpected safety findings, and there were no deaths. So I think the trial was very nicely done. So you have these polling questions. I don't know if you answer them on a phone. I don't know. Okay, all right, cool. The first question is, the rate of kidney function decline over 2 years on iptacopan was approximately 2/3 of placebo, 1/4 of placebo, 1/3 of placebo, or half of placebo. All right, let's see who is actually listening to me. Do, 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 do. I don't think it shows the results. Does it? No? Okay, tell me when you're done. I'll tell you the answer. Okay, it's half. So -6 to -3. And remember, -3 is better than -6 because it's sort of... All right, at month 24 in the APPLAUSE trial, iptacopan reduced the number of patients reaching a kidney failure endpoint compared to placebo by how much? This is really hard. It's like it goes up by 10 each, 23, 33, 43, or 53%. Okay, somebody said C. You win. Okay. These are all the participating investigators scrolling through. Obviously, a great thanks to the teams that did this worldwide. And as Sydney said, we couldn't do this without our patients participating in these trials, and they're the real heroes of this, and hopefully they'll reap the benefits of these new medications. So I am happy to take questions. Thanks.
Here's a question.
Hi, I'm Steve Burke from Akebia in Boston. The fact that the GFR did decline over that year, the annualized decline, do you think that's related just to that's just the way it's got to be, or is it could you have more intensively inhibited the complement system? And do you have any complement-related biomarkers that speak to that issue?
Well, the session before was all about complement biomarkers, and I think you were there, and they said there aren't any biomarkers. There aren't any. So that is really an issue. I do have some thoughts on your question because we think about this all the time. If you look at the latest thing from KDIGO we put out, it's just come out in Kidney International, we have a table of GFR declines and a table of of proteinuria decline. No drug is making the GFR slope go to 0, which would be what we want, or -1, which is after the age of 40 what we have, and no drug is making all of the patients go to a proteinuria of 0, which brings me to my thought, and then I'll say except in a minute, which brings me to my thought that really what we're seeing is we probably have to combine these drugs with different mechanisms of action where they act on the complement pathway, on the forehead hypothesis, to actually achieve the levels we want. Okay, it's not a knock against any single drug, right? It's just that, yes, I think it's the way it is, and one single mechanism in that big pathway is not going to be sufficient. So that's one thought. The except is what we are seeing, not in phase 3 yet, but in phase 2, the decline, the slope in the B-cell modulating drugs, the APRILs and the APRIL-BAFF inhibitors, in the phase 2 has been close to 0. I've never seen anything like that in anything I've done for my whole life. If that bears out with the phase 3 trials, that will be a remarkable finding, that a single drug category can actually preserve GFR to that extent.
Mala Sachdeva from North Welland, New York. Thank you for this fascinating talk. I have a fun question for you, actually. So I saw that of your participants who were on the med, one got pregnant. And I do a lot of OB nephrology, see a lot of GN during pregnancy, and we know how limited we are with medications and pregnancy. So the one discontinuation because of pregnancy, has anyone followed? Do you know what trimester she was in, or any follow-up in terms of outcome and so forth?
Thanks.
Fun question.
No, it is a good question. Admittedly, I don't know that, but I will, since I know you, I will, I will follow up with you and find out. Inevitably, due to our best efforts, people get pregnant on these drugs, and most of the time it works out okay. I don't know what the outcome of that was, but my guess is it wasn't a bad outcome, or we would have heard about it. So I'll follow up. But great question, and you're absolutely right. How do you treat these diseases during pregnancy? Because taking a hiatus of any of these drugs for 9 months, on top of increasing the GFR and glomerular hyperfiltration, probably doesn't do the kidney any good, I would guess. Am I right?
100% agree.
Okay, good. I like to be right.
I think this would be great to look into. Thank you.
All right.
Hi, I'm Mark Brown from Sydney, Australia. Thank you for the presentation. I'm intrigued that 75% only had hematuria at baseline.
Yeah.
I presume the other 25% must have had proteinuria to even get a biopsy in the first place. Do you have an analysis of those two groups, those with and without hematuria at baseline?
We haven't, to my knowledge, we have not done that analysis in the iptacopan or the APPLAUSE trial, but a couple things. Remarkable to me, too, is that there were a lot of patients in all the trials that had no hematuria, and it was pretty much just like this. About 30% of the patients did not have hematuria. And I know that at least in the NEFCON trial, I believe we have analyzed that, and I don't think it's been published yet, but it may be an abstract that's coming, maybe even at the ERA. But it didn't really, to my recollection, it didn't matter whether they had hematuria or not, the drugs still worked. But we should look into that more closely. Almost all of my patients have hematuria. It's sort of the clue, right?
Yeah.
But yes, the remaining patients that didn't have hematuria in this trial were proteinuric, for sure.
Thank you.
Thanks for an excellent presentation. I read the New England Journal of Medicine article, and in the introduction it mentioned that 90% of patients with IgA on biopsy have complement staining, but I think you implied that you think that it should be 100%, or does that inform decision-making, or have you looked at complement staining and?
Yeah, this is a really hot topic. So when I talk to some of our really preeminent nephropathologists, they tell me that almost everybody, so close to 100%, will have complement if you do specialized microscopy, okay? Not what we do clinically. So more study-ish or investigative. And no, we can't relate, at least yet. We're dying to relate the complement deposition, complement factors in the urine. We haven't been able to do that. I know that with iptacopan, for sure in the phase 2 trial, we measured both systemically and in the urine complement C5b through 9 and other split products, and it just takes everything out. I mean, it clearly inhibits complement, but none of those seem to be a good enough biomarker, at least in the way we're using them. And I'll just, we got a minute, right? Okay. So I'll just tell you, I presented this last year. We've measured complement in our IgA patients, and what's fascinating to me is that when I look at C5b through 9 in the urine of IgA patients, or BB, or BA is what I measure in the urine, those actually associate more with the T lesions and the S lesions, presumably chronic damage, than they do with inflammatory damage, which the E lesions, which is amazing to me, right? Because it was the exact opposite of what I thought would happen. Now, the criticism of that is the S lesions might be, some of them might be inflammatory, but the T lesions are not inflammatory. So I would suggest that we have a lot more work to do to figure out how to understand in which patients the complement system is really where we want to attack. But right now, if you were to ask me, who do I pick, you can pick anyone. You can pick anyone that matches the trial, because we can't distinguish one subgroup from another. Okay.
Other questions? What future trials that will compare agents?
Well,
what will we be looking for in the future?
So the future, so we're going to finish up it's not even, the odds are even. We're going to get the Aprils and April BAFs. They're going to become approved by regulatory agencies unless something tremendously weird happens in phase 3. So those will be available for use, and one of them is available for use now. Then going forward, what I think you're going to see is a whole new category of drugs, and they might be talked about here a little bit, that bind and clear galactose-deficient IgA from the circulation, either clearing it from the circulation with FcRn blockade or by actually digesting it. And of course, the presumption there is that galactose-deficient IgA is the culprit, right, is the pathogenic molecule. What's nice about it is you're only removing a portion of the IgA and you're not hitting any other parts of the immune system, so it's not going to be immunosuppressive. So that's really good, or immunosuppressive to any great extent. The other drugs that are coming down the pike, which are very interesting, are the plasma cell inhibitors, or the plasma cell agents. They kill the plasma cells. So again, for the audience, you all know this, plasma cells are sort of the end stage of B cells, where they've transformed into the cells that make antibodies. And there's 2 CD38 trials that are happening right now, and these kill the plasma cells. And those trials look very good as well. And what's fascinating about those trials is when the drug is stopped, when these drugs are stopped, the disease comes back fairly quickly. When those drugs are stopped, the disease doesn't seem to come back, at least for the time that we've looked in the trials. I think it was up to 96 weeks. And so that really begs the question of what's going on. And the other thing it begs is that in one of them, the galactose-deficient IgA came back right away, but not the proteinuria or anything else, suggesting that maybe galactose-deficient IgA is not
the culprit. So I think the trials were banking on the four-hit hypothesis, but I think the trials are teaching us how we're going to need to modify that hypothesis over time.
Great. Any other questions?
All right, thank you.
Thank you. I want to thank our speakers today, Sydney Wong and Brad Rovin, and thank you for submitting your abstracts for the spring clinical meeting, and enjoy the rest of the meeting.